Today we'll be talking about Cushing's syndrome. It's an endocrine disorder with prolonged elevated levels of plasma glucocorticoids, such as cortisol. The source of these excess cortisol may be exogenous in nature, possibly from steroid use, or it may be endogenous in nature, for example, a pituitary tumor that leads to excess release of adrenocorticotrophic hormone, which leads to excess cortisol production. This specifically is known as Cushing's disease, something that causes Cushing's syndrome. This video will explore more detail about Cushing's syndrome. It will compare the normal and abnormal function of the systems involved in Cushing's syndrome. It will look at the pathophysiology of Cushing's syndrome. It will look at the key signs and symptoms, and look at pre-hospital management for someone with Cushing's syndrome, as early identification and management of these patients is very important, as Cushing's syndrome has a high morbidity and mortality if left untreated. Normally, the hypothalamic pituitary adrenal axis functions with the hypothalamus synthesizing and secreting corticotropin-releasing hormones into the portal vessels. This stimulates the anterior pituitary gland to release adrenocorticotropic hormone into systemic circulation. As ACTH arrives at the adrenal glands, it travels to the adrenal cortex and binds to MC2R receptors on the adrenal cortex. Specifically, the adrenal gland is composed of the adrenal cortex and the adrenal medulla. The adrenal cortex is split into the zona glomerulosa, zona fasciculata, and zona reticularis. Upon binding, ACTH causes several intercellular changes. It stimulates the zona fasciculata region to release and synthesize glucocorticoids, such as cortisol. It also stimulates other parts of the adrenal cortex, releasing aldosterone and androgens. Cortisol is a steroid hormone which plays a large role in the body's circadian rhythm and response to stress. It has widespread impacts in the body because of the presence of glucocorticoid receptors in several parts of the body. In stress, cortisol influences glucose metabolism by increasing gluconeogenesis, which is the synthesis of glucose from non-carbohydrate sources such as fats and amino acids. It also increases insulin resistance to maintain energy levels within the body. It also causes cardiovascular changes by increasing sensitivity of peripheral blood vessels to adrenaline. This naturally causes vasoconstriction and increases cardiac output and blood pressure. Cortisol also has anti-inflammatory effects as it reduces the production of inflammatory mediators and hence has an immunosuppressive quality. Once enough cortisol has been produced, cortisol has a negative feedback effect on the hypothalamus and the anterior pituitary gland. Specifically, it causes a reduction in production of corticotropin releasing hormone from the hypothalamus and causes a reduction in adrenocorticotropic hormone release from the anterior pituitary gland. This subsequently has a cascade effect down the HPA axis, eventually reducing cortisol production and returning it to maintain normal levels. But in Cushing's syndrome, we get abnormally high levels of cortisol due to various possible reasons. One of these reasons is endogenous causes, which includes and refers to causes that occur within the body. This may include pituitary adenomas, which are a type of benign tumor. By benign, I mean a tumor that does not spread to nearby cells. Being a benign tumor, pituitary adenomas are the most frequent cause of endogenous Cushing syndrome. This results in the hypersecretion of ACTH via the pituitary gland and the adenoma itself. This naturally causes excessive stimulation of MCR2 receptors in the zona fasciculata in the adrenal gland, eventually causing the adrenal glands to become hyperplastic. Hyperplasticity refers to an increase in the number of cells of a tissue. This causes an increased amount of cortisol release. The adenoma of the pituitary gland also reduces its sensitivity to cortisol negative feedback. This further enhances ACTH release and causes an effect on increasing cortisol levels even greater. Some other endogenous causes of Cushing syndrome is adrenal adenomas and carcinomas. Carcinomas being malignant tumors, meaning that they can spread to other cells, and ectopic ACTH release. All these causes cause an excess release of cortisol without being stimulated by ACTH. However, the excess cortisol that is produced has a negative feedback impact on the hypothalamus, resulting in a reduction in the release of CRH and ACTH. These hormones naturally cause zona fasciculata to undergo atrophy. By atrophy, I mean shrinkage. This is because these layers require consistent stimulation to maintain its function and size, and being less stimulated by ACTH leads to its shrinkage. Nevertheless, cortisol levels remain high because of the adenoma on the adrenal glands. Finally, ectopic ACTH secretions, such as ACTH secretions from lung cell carcinomas, can cause excess ACTH release as well, contributing to excess cortisol production. However, we can also have exogenous causes of abnormally high levels of cortisol. Exogenous refers to outside of the body. These primarily include taking steroid medications for a range of inflammatory conditions such as asthma or rheumatoid arthritis. Steroid medications have a similar structure to cortisol, mimicking its effects. As a result, these steroids can cause negative feedback on the hypothalamus and pituitary gland, reducing ACTH levels in the body. This also causes decrease in size of the zona fasciculata, subsequently also reducing the size of the adrenal glands. The levels of cortisol remain so high that the net change is an increase in cortisol levels despite the shrinkage of the adrenal glands. The number of cortisol molecules in the body can cause several complications and symptoms. One such example is an increase in weight. Excess cortisol can influence glucose production by binding to glucocorticoid receptors on hepatocytes, which are cells in our liver. This causes gluconeogenesis, in which fats and amino acids are converted to glucose. It can also bind to other glucocorticoid receptors around the body, converting other things such as fats, amino acids, and proteins into glucose. The net result is an increase in glucose levels in our bloodstream. It also causes peripheral insulin resistance. The result of both of these factors is fat accumulation in adipose tissue, as the body aims to compensate for the chronic hyperglycemia. The fat tends to accumulate centrally, causing accumulation in the cheek, face, and abdomen. A key sign is fat accumulation at the back of the neck, colloquially known as a buffalo hump, and around the face, leading to facial roundness and something called moon face. It can also cause symptoms in our skin. Abnormal levels of cortisol also cause the breakdown of subcutaneous connective tissue like collagen, weakening the skin's structural support and causing structural damage to our capillaries. The result of this is easy bruising due to the capillaries rupturing more easily and formation of purple striae throughout the body. The striae may also appear due to stretching of the skin from increase in adipose tissue. Cushing syndrome can also cause cardiovascular symptoms. First of all, it can cause hypertension due to a multitude of reasons. Firstly, it increases sensitivity of peripheral blood vessels to adrenaline, causing vasoconstriction and increase in venous return and hence blood pressure. Also, as a glucocorticoid, cortisol has a similar structure to mineralocorticoids, such as aldosterone, causing upregulation of sodium channels in the kidney tubules, leading to water retention. The increase in blood volume naturally leads to an increase in blood pressure. It also has musculoskeletal and osteological causes and symptoms as well. Excess cortisol can cause muscle weakness and bone loss. This occurs because high levels of glucocorticoids are known to cause breakdown of proteins that make up skeletal muscle. This leads to muscle fatigue and breakdown. It can also cause decreased absorption of calcium from the intestines, reducing the amount of calcium that is available to form our bones. This increases chance of acquiring osteoporosis and increases chance of fractures. Cortisol is also known to inhibit the body's normal immune function by reducing the production of inflammatory mediators. This increases the chance of acquiring an infection. It is also known to cause emotional and psychiatric conditions such as changes in moods, depression, cognitive impairments. This occurs possibly because of glucocorticoid receptors in the brain cortex. Although there is ongoing research, this is suggested to be a cause. Pre-hospital diagnosis of Cushing syndrome is very hard as it's a very rare condition and it may present with several symptoms that are very similar to other conditions and hence require extensive testing in hospital. Nevertheless, there are certain indicators that may be possible to suggest the condition. A history of recent steroid use due to inflammatory conditions such as asthma or rheumatoid arthritis may suggest Cushing syndrome. However, this needs to be combined with other key signs and symptoms such as increase in weight since steroid use, purple striae formation on skin, recent history of muscle or bone weakness, hypertension, or changes in emotions are some key symptoms. The combination of these signs and symptoms could be strong indicators of Cushing syndrome. Nevertheless, Cushing syndrome may have an endogenous source, making it hard to make the connection to the condition by simply seeing the above symptoms, as the patient may not be taking steroids. There have also been cases in literature where not all the symptoms were present in patient, making it even harder to determine Cushing syndrome. Pre-hospital management of someone with Cushing syndrome requires important consideration that the patients may feel very weak and fatigued and be at greater risk of fractures. Therefore, weight distribution and method of extrication and transport need to be considered carefully to limit possible injury. Also, in patients with Cushing syndrome, they may already have a minor stable fracture, so pain management and symptomatic management will need to be considered. Furthermore, these patients may present as hypertensive and are also at greater risk of infection and possibly deteriorating into septic shock due to the cortisol-induced immunosuppression. Therefore, monitoring of key vital signs is crucial, and consideration of rapid transfer to hospital in patients presenting as severely ill is very important. In general, we need to think about symptomatic management. Thank you for watching my video on Cushing syndrome. In general, Cushing syndrome is a hard disease to diagnose as a paramedic in pre-hospital conditions, but all we can do is provide symptomatic management for our patients.